Aloha, I am Mark Alexander, Executive Director of the Hawaii Medical Association. Welcome to tonight's Conversations at HMA, a program which features discussions with physicians and other thought leaders on healthcare issues. Tonight's panel is entitled A Conversation with HMSA Leadership, Shaping Hawaii's Healthcare Future. Before introducing our panelists for the evening, a few comments on logistics. For those who are on our Zoom webinar, we invite you to participate throughout the 1-hour conversation by submitting your questions, comments, issues on the Zoom Q&A function. We'll try to feature as many of them as possible, but in any event, we will pass them on to the panelists after the event. For those who are in the room, we invite you to submit any questions, issues, concerns on your index cards and give them to either Mark or myself. And again, we will share as many as possible. Plus, we will be able to continue the conversation after the formal part of our presentation. Now to introduce our panelists. Dr. Mark Mugiishi is CEO of HMSA and a surgeon. Ms. Jenny Smith is HMSA's first woman president and also the chief operating officer, a lawyer by training, and also holding an MBA from Loyola University in Maryland. And our moderator this evening will be Dr. Nadine Tensal, HMA's current president, and also a practicing internal medicine and pediatric physician. Welcome to all of our panelists and welcome to all of you. Dr. Tensal.
Good evening, everyone, and aloha. And on behalf of Hawaii Medical Association, mahalo for joining us tonight for our discussion with HMSA's leadership shaping Hawaii's healthcare future. Tonight's conversation comes at a moment for healthcare in Hawaii, at a time that there's significant change, challenge, and opportunity. Physicians, health systems, insurers, policymakers, and community leaders are all asking important questions about how we preserve access to care, support a sustainable physician workforce, and ensure that Hawaii's healthcare system continues to serve patients and communities across the islands. We're grateful to have the two leaders from HMSA who are helping to shape our future. Dr. Mugiishi, we appreciate your willingness to engage directly with the Hawaii physician community this evening. I also want to extend a warm welcome to Jenny Smith, Hawaii's HMSA's new president and COO. And I also wanted to point out that we are extremely grateful that you are building roots here in Hawaii. It's our understanding it's your husband, your son, who's now at Iolani. You were sharing a little bit earlier with us that he is a basketball fan and just being a part of the community. And I understand you're also involved with the Chamber of Commerce for Hawaii. But tonight's discussion, we are going to try to make it as future-oriented as possible. The questions we're going to discuss this evening are going to reflect themes consistently raised by the physicians and healthcare leaders across the state. A lot of this will touch a little bit on the transition of leadership at HMSA. We will not necessarily speak about the overall vision of the HMSA HPH One Health Hawaii affiliation, but we're going to ask for an update. And then we'll shift over to the broader questions that the community has been asking most recently around the payment reform transformation, administrative burden, and what are some of the goals and strategies for our neighbor island physicians. So we'll start with leadership transformation. And the question would be, internally for HMSA, you've obviously made a decision to bring on new leadership, but externally for the Hawaii healthcare community. And I ask this question to both of you. What does this mean? You want to start, Mark?
Yeah, I'll kick it off. First, thanks so much for having us, Nadine, and Hawaii Medical Association for having us. I always tell people the physician community is really our product. It's what we put out there that delivers health to the community that we serve. So we appreciate the partnership that we share with you. Healthcare has gotten complicated. It's hard. There's a lot of change in the way health is administered, the environment in which we have to operate. And it became necessary to think about how we function as an organization, both outwardly facing and inwardly facing, how our operations run versus how we show up in the community. And so, quite frankly, it became a lot. And for me as the CEO, I said, I need help. And I need help, somebody who has expertise at really understanding health plans, how they work, how they can evolve with changing times, and was very, very fortunate to be able to find Jenny Smith. And she can share a little bit about her background that shows how lucky we are to have her in Hawaii, that can help buffer and really bring forward the internal operations of HMSA to make it the best health plan we can have in Hawaii.
On the tail of that, share a little bit about your background and maybe a little bit what will change in terms of your responsibilities versus Mark's responsibilities and leadership.
Good. Thank you. First of all, I'm grateful to have this opportunity to sit right next to Dr. Mark, and we don't come out together.
No?
Yeah. And it's a rare because it's sort of you're going to hear more about how we divide and conquers, and given the mounting just amount of work and the change required, started with the HMSA ourselves. Okay. But a little bit about myself. I thank you for the great warm introduction. I have a little bit interesting, weird background. I bounced around, law schools and going to the business schools. And I was stumbled into the healthcare and health insurance space 25, over 25 years ago now, 26, 27 years ago on the East Coast. It's just by a chance, I was recruited by Kaiser Permanente Mid-Atlantic States region from a DC area, and started my journey in integrated systems. There's Kaiser region here. Many of the clinicians maybe even have a family, friends, practice in that circles. We all know that model is about. But even within Kaiser, I was extremely privileged, have an opportunity working on the 3 different legs of the integrated systems. Mostly is in the health plan capacity, but I did spend the 3 years working exclusively for the medical group about physician practice. That's over 1,000 clinician, primary care specialist, hospitalist. I learned a great deal from the physician around what is the hardcore of the managed care and what is the heart and soul about quality and prevention. And so that is a privilege. It even carried me until these days. Then opportunity arising, I had the opportunity to be transferred to Northwest region. And other than California, Northwest Kaiser region has 2 owned hospitals and a 5, network systems. I always want to run a hospital. Working at Kaiser without running a hospital feels like it's such a missed opportunity. It really got into more of an operational and mindset, and appreciate staffing challenge, workforce. In a certain space, you have a staffing ratio required by the states, navigate through up and downs of the operational nuances, hospital qualities, how we continue to stay true to the integrated care, push the care to the left. It's very humbling about get your first hand of how patient is the center of everything. Then I always have a leg into the health plan from a strategy and a finance space, from a corporate, some of the M&A activities. And because Northwest was part of I had a chance to participate in part of a group health era and journey. Now later on becoming KP Washington. So it was great. I spent 20 years in I would say every different corner of the integration circle, and I hope to carry that and adapt it whichever local market I'm going into. Currently in Hawaii, it really brings some impact. Just a thought process, how we using local solution and apply some of the learnings to really partner with the local provider community and try to deliver same triple aim. I went to East Coast, back in the East Coast again, joined Care First Blue Cross Blue Shield. That's about over 3 million size of a membership, 13 billion in revenue size, and became their CFO, get to understand from a purely a payer, not-for-profit payer perspective, what's the challenge and dynamic, and a strength. And purely from a payer side, you get to compete with the national. You're probably tech heavy, using system as a way to influence the care provided. You do have a scale, but bring a different dynamic, how we partner clinician differently. It is also an all-payer state. I think it's more advanced in a nation from a really negotiated hospital rate. It creates a lot of a stable environment for provider community, operate in that dimension, can focus on quality and appropriate utilization without competing with a price negotiation. And comes with fatigue too. And I can see the era, 10 years coming in the recent time, why all that model started to show its limitation. If there's a quick learning here, there's really not one single model last forever. Yeah. You don't have to go too far away from it. Healthcare by and large is still not the most fast-paced evolving. Mm-hmm. And the last 3 years, we feel the fast pace for healthcare compared to other industries still relatively well measured, because you impact people's, impact outcomes, impact patients, but change is coming in a way. It really testing any model is lasting for its good of time. So it creates a learning agility for all of us. So then when this opportunity came up, I was in the stage, really kind of, we're looking for a mentor, how to challenge myself to continue, make a greater impact. I was joking with Doc a little bit that I think Doc probably see my son can play basketball for Ilani's, and then therefore somehow I'm here. But really it was it's inspiring. And I actually never worked for a clinician in a health plan capacity. Itself is kind of fascinating, right? How clinicians see that from the other end. But for the things Docs have been done in his role for HMSA in this market, it's really not a typical health plan CEOs just sitting there from a plan perspective. Mm-hmm. And the mission itself, it goes beyond even a typical not-for-profit healthcare companies, just the member-centric. And it dawned on me when he first said it was anything good for Hawaii is good enough for me. I was just taken aback. It's kind of new height, new horizons. Like, well, that is fascinating, So it's personal admiration, and the geography itself, in my mind, has a lot of potential and opportunity. It's curiosity. And also at the time that I think healthcare is going through some tremendous shacking. So the combination of that make me very drawn into this prospect, and also career personal growth. So long way to get to your last question. The change really is a response to the market, the business, the provider community, our employees. It's mandated to the leadership of HMSA. You got to figure a path forward to carry our responsibility. So allow the organization continue to serve the community for the 80, 90 years to come. And we all both realize it's just too much. So we get to this place about divide and conquer, and where we can pressing the vision, becoming a full-time job. Dr. Marks is leading, no regret. He's gone. Okay. Meanwhile, the plan itself does require a lot of retooling, upscaling, commitment to our talent and local resource in the here now. It's not short.
Just briefly then, in this changing environment, HMSA, and to a certain extent, Dr. Mugiishi is well known to the community. Here you come in as relatively, healthcare is just moving rapidly, right? It normally moves at a much slower pace, and we'll all acknowledge it's moving rapidly. What do you think you're going to bring to the table that we should be looking out for with regard to HMSA?
I have colleagues here. They all have a nickname for me. I move fast
Okay.
and
But what do you want to move?
everything. I I would say you can only move fast if your team's willing to move with you,
Okay.
and the system and team, internal, external, can see align with the progress we are making.
Okay.
And every step away is always a validation reflection about that makes sense.
Okay.
And frankly, to some degree, it's about a little bit discomfort. If it's too comfortable, kind of a, we can all think back, are we falling the same trap again? We are charted a different path that do want to allow a lot of empowerment, calculated risk takings, and go to some place that we haven't gone before.
Okay.
It's a test for all of us. Myself
And
included.
I'll
Go ahead.
I'll just share my expectation of why I'm excited about Jenny being here. So HMSA has 3 lines of business. We have our commercial line of business, we have Medicare, and we have Medicaid, and we are committed to all of them. It's part of our mission to take care of the people in Hawaii, regardless of the line of business that they're part of. Healthcare has changed tremendously, where technology is a bigger and bigger part that requires investment, it requires skill, it requires analytical understanding to make it all happen. All of those things together are expensive, and trend is higher and everything's higher. So we brought on Jenny and we said, make us sustainable. We want to do all of this. We want to do everything because the people of Hawaii deserve it. Our families, friends, neighbors, they deserve it. But we are struggling with a future of sustainability. So
Internally.
make us sustainable.
So let's go to one of the projects that you've put out that I think is in line of sustainability, the Hawaii Pacific Health HMSA affiliation. And I don't really want to go into its overall vision and why it should exist. Instead, I thought we could use this moment for you, the two of you, to update us. Where are we with the general timeline? What is the community expecting from a legal perspective? When I say legal, in terms of filings and such, and then maybe a few more questions after that.
Sure.
Yeah.
Yeah, we won't go into the details because I think people who are interested have heard a lot of it. But since this is a provider-centric meeting with the HMA, I would just like to encourage everyone to take the names out of the equation, take HMSA's name out, take Hawaii Pacific Health's name out, and just say, what do you think about the concept that care delivery providers get to determine how the money is spent? And I would think people would just love that idea. And that is what the idea of a vertically integrated system tries to accomplish. So,
but more specifically, in terms of where is it in terms of its steps legally?
yeah. So now in trying to get to that, we have regulators that are taking a look at the deal to make sure it brings the value that we say it's going to bring, that it doesn't disadvantage anyone in the community who needs to not be disadvantaged. And so we have 2 steps. We have a federal regulatory process that's being conducted by the Department of Justice, and they are in the middle of their regulatory review. We expect typically these take 6 to 9 months. So we're hoping that by the end of the year, they will have their findings. And our company right now and Hawaii Pacific Health are going through the ringer with like tons and tons of questions. 51 questions, I think. Jenny's areas are in the process of answering those. So that's on the federal level. On the state level, we have the Attorney General and the State Health Planning Development, SHPTA, are looking at it as well to make sure, again, that it meets state planning, regulatory, like this makes sense for the people of Hawaii. And with the AG, just make sure that it protects the competition, fair competition in the market.
And the state and the federal are concurrent, or one, it has to pass through the federal before it goes to the state?
They are concurrent, but they're looking at different issues. I think the federal one really looks at it from the lens of the Sherman Antitrust Act and what's the legality of this. I think the state and SHPTA are more broadly like, is this good for Hawaii? And that type of analysis.
My next question would be, it's almost assuming that it goes through, and this is a very pointed question that has come up over and over. For those who are not in the first two acronyms of the affiliation name, HMSA and HPH, what is HMSA going to do to ensure equitable relationships with the providers and the systems outside of One Health Hawaii?
The license of a Blue Cross Blue Shield sits in HMSA, and we are regulated by NAICs and also local regulator, our insurance commissioner. The our intangible value as our brand itself, and with a close 90 years history, is a open system. And frankly, that's the value. If anybody want to merging or affiliate with us, is the market presence, reputation, long history, and the choice we offer to the community and people of Hawaii. That is a table stake, which require us to continue operating in the open systems with a defensible and a credible, auditable market conduct per se. And there are other states literally have a state issued market conduct exams that is the service we acquire, we procure on members' behalf for hospital system, for provider systems, have to be equitable and defensible based on the quality and outcomes. So that's the guiding principles that HMSA will always, in a fair-based contractually, if not strategically, develop partnership and procure service arrangement with all willing participating providers. And we are open network for all the islands and the entire state, and including the service for the member seeking medical care outside of the state of Hawaii. So I just want to make sure that's very clear about how we don't really treat anybody provider space system-wise with a differentiation.
Does that mean then, because of its significant role that HMSA plays in the community, that there's an intention from the beginning, or the get-go as the expression would go, that there is measurement of how services are provided and whether or not there actually remains an open access for specialists throughout the health system, so that services cannot be concentrated, for instance, in One Health Hawaii, or there can be decisions not to provide certain types of services, albeit expensive services, within one system and leaving it for the rest of the community. With realizing that you cannot control all variables, does HMSA intend to at least measure and be able to react if the market gets shifted in this direction?
Yes. So I think the goal of any mature managed care system, which is what our goal always has been to create, is to make sure that care is placed in a system that can deliver quality, sustainability, population health, health equity, and well-being of all the providers involved in managing that care. It is the goal of HMSA to always have those go to the places that can deliver that. And that can be One Health, it can be anywhere else. And our goal is also, because Hawaii is limited by our geography and the fact that we have what we have, is to get everybody to that place. Because we need every one of those providers to have that capability so that we can manage care for the whole population of the state.
The rest of it is purely economics of the healthcare distribution on the island. That this is not a excessive provider workforce state or community. Just don't have enough. So it's not a saturated market, and it's not all of a sudden the docs competing for the volume as if I don't have enough volume to keep my practice. over the years, I think that more of a struggle on the other side. Certain specialists are becoming less and less sustainable, and more care goes into over the sea seeking cares, and some more of a high advanced, not even the medical care or surgical care, even the ancillary, type of a facility equipment is not quite there yet. So we are moving a different direction, more scarce in a way, and on the state, the workforce is more fragile. Some neighbor islands practitioner is just aging. Collectively, we have a real daunting challenge, and not just sustaining to take care of an aging broader population, which is in a faster pace compared to the rest of the states. How we have a workforce can keep that trend on the same momentum. So it would require some kind of innovation with a like-minded community together with the providers to solving that supply-demand issue, and with the intensity of the demand, not just the purely a numbers games. So I don't see at all any system will be disproportionately impacted because the volume shift. In fact, we need all of it. But even with all of it, I still think it's a gap. So therefore, the innovation piece coming in is how we sort of a fast pace into the next iteration of how to redefine the supply and demand. How do we take the duplication out and really button down on the support mechanism, allowed our fewer clinicians working to the top of a license and with some kind of support mechanism.
With that, let me transition to our next topic that I think will expand on some of what you just said. And this has to do with the fact that for somewhat of almost a decade, the community, particularly the primary care community, which includes internists, family practitioners, as well as pediatricians, they bought into the payment transformation. I'm not saying they went willingly. It took a lot of negotiating, but at the end of the day, the majority of primary care physicians bought into it. It is a different way of delivering care, and some of the language that is being used to describe, for instance, One Health Hawaii sounds very similar. And I won't argue whether it's good or bad, but just a couple of weeks ago, the community received letters that basically gives them 60 days notice to transition to fee-for-service. And one could argue on paper, one can survive in fee-for-service. As a matter of fact, we've for decades have survived on fee-for-service, but the entire model is different. Staffing is different. How you manage your single solo practice is different. You have to plan in a much, much different way. Speak to the community a little bit on one, why such an abrupt and rapid shift? What part of payment transformation do you HMSA still believe in, or are you phasing? Or maybe you can explain to the community the reasoning behind the abrupt change, and what does this mean for those who basically for the last decade have tried to evolve their practice and their business models to meet the payment transformation model?
Let me just start with 1 minute of the very high level, because historically, I think Nadine, before I was CEO of this company, that was my job, was to roll out this payment model. So it's near and dear to my heart. I believe in population health. I believe in value-based care. So I'll just start by saying the goal of HMSA is the quintuple aim that we talked about before. The strategy to get there is to develop a mature managed care infrastructure ecosystem here. And the tactic was a payment model that tried to get us there, which was this payment transformation model. We learned a lot of things over time, like maybe it wasn't broad enough. It didn't include specialists and facilities. But it was a great start. It was a great concept. I still believe deeply, and that's how we want to do things. But a lot of things have changed. The world has changed, and the model has fatigued, and it's it's not giving us the desired impact anymore of the 5 things that you need to reach that quintuple aim. And that's where we started to think about how do we have to change to get there. And that's where I'm going to let Jenny take it from here because she could explain our thinking about why it's different and where we hope to go from here.
I think that's where just want to stop a second, talk about it's hard for a mature organization to take a step back, examine the strategy we held dear to our heart. We put our reputation and brand behind this for a decade.
The immature organization is HMSA?
No, it took a mature
Oh,
organization
mature.
to
Okay.
to examine
Okay.
your own product out there that we articulate to everybody, right? Because we really believed it. And the concept is taking a one giant step forward to release the burden for primary care clinician. But the forward looking for this is really intent to create an environment, have the primary care as the quarterback, population-based care, prevention, longitudinal care, and really allow that whole mechanism influence the rest of the provider market. What has changed? And by the way, before we get there, we actually made a substantial investment. And HMSA spent roughly about 10% of medical cost on primary care, medical cost. If you include the drug benefit, that's about 7% in primary care. That's a nationwide leading. National average about 4 to 5%. And so put the mouth to where you speak for. And that's not 1 year, 2 year, a decade. Life does changing on you. And 10 years later, particularly post-COVID, we see a couple pretty significant shift, you know. HMSA's members access does feel challenging to get to the PCP level. And usage of often you end up in the ERs or urgent care settings. When you're getting basic primary care for those settings, the clinicians more than anyone else, better than me, knowing the bounce back rates. You guys still got to check in with the primary care clinicians. The coordination of care gets suffered, and so on and so forth. The second piece is just dirty laundry. You know, HMSA, we actually put a tremendous investment onto the driving this model. Our back office is underinvested. So you're using human being to managing the attribution. And over the time, becoming such a burdensome through our listening session with the clinicians, that's the number one noise about make it so complicated. It was difficult to follow. And our process to administer that is also becoming unsustainable. And the next one is actually, I would say, today's regulatory environment evolving dramatically. And I walk away from the operational meetings, right? The government program, CMS, our local regulator, increasingly demanding for evidence-based activities. So the demand on the data accuracy, timeliness, clinical data capture, use that as a compensating factor to justify the revenue and the capitation. So either claim or encounter. And without that firsthand of information, forget about just justify your revenue. It's kind of a tinted away about population care. That's the core. And the last one probably is a structure that Blue's very good at PPO. Our winning ticket, you have one car, you go up wherever it is. Mm-hmm. In the hindsight, look back, is a primary care capitation model shows its fatigue to the extent that I grew up in the systems, maybe I have a biases. Population-based primary care model works best in the tightly integrated infrastructure support, which is tech, and an integrated system, referral patterns. You got to support the primary care doc, have a sandbox to be able to manage longitudinal care. In a PPO environment, it's just so hard for put all the burdens on the primary care to reach the hand far away, get to the utilizations, which facility you're going to, and skip the specialist, it just a little bit less realistic.
But I think you're bringing up several things. First, the bravery that HMSA took a decade ago to attempt this, and that they were not able, both internally and externally, able to control as many of the variables that are needed to be controlled for it to be successful. We've talked about this in the past. You need control of your patient panel, and you have an open system, therefore it's challenging. The second thing is that you need to be able to risk stratify your lives so that you cannot offer the same across the board, but be able to offer higher levels, more coordinated services for more complex patients. Fair? So you basically, we move forward a decade later, and if we're going to use a sort of a figurative table of all the individuals or individual entities that are part of decision-making of healthcare in Hawaii, HMSA only one of them, albeit a significant one. Can you speak to the fact of such a short turnaround in which, even if they want to follow the decision that HMSA is taking, that it is an exceptionally short period of time, especially when we talk about private practice, solo practice, rural physicians who are practicing on a much, much tighter margin often, to be able to turn their entire business around in 60 days. Was there potentially a loss of opportunity to engage the clinician community beforehand? And if there was, while we may still go in this direction, is there an opportunity to create a softer landing and maybe a transition to help these clinicians not literally run aground, as they may have to consider closing their doors if they cannot, adjust to this new change rapidly?
I think it's talk about mitigation and how we engage the community for this. HMSA has been go through a journey. I mean, our reflection is a self-transparent, data-driven learning organization on ourselves. So I would say it takes almost over a year for us internally getting aligned with a couple different independent consultants who look at the data and started to socialize the idea with a physician organization. Those are the POs in the market. It's not a brand new conversation to have, and we started that last year. Part of the listening from their point of views and what worked, what didn't work well, what we want to see and move forward. Through and through, I would say this is not about HMSA deviated from our commitment for primary care model. We just have to retool it. This is the step one, okay? Our action go out is kind of started last year. We turned the Medicare into fee-for-service in September 2025.
But those are internal movements. The community received notice just a couple of weeks ago, and that's what they're going to respond to. Despite,
I think what she's saying is in 2025, we changed all the physicians
for primary care,
Okay.
for Medicare. So I think that's the constituency. Now, you may argue, should we do more in-depth listening beyond the PO structures, right? But over the years, I think a PO and HMSA really developed an intense relationship. Think about it as the support mechanism to how to influence. And we do rely on their role for respective clinicians. We changed the Medicare fee-for-service last September.
Okay.
And with always the understanding about what's the next to come. And we are partnered with MapQuest on the AHEAD model together, and the government intend to roll that out in the 2028. We went through the stakeholder discussion with MapQuest as well about all the change coming upon in the July 1st. And I think it's really not, any time is a good time. We're anticipating community going to feel the shock. And we also develop a set of a mitigation plan to help support the transition with a couple fold. One is the principle of the change was never try to displace individuals, especially independent, because it's smaller scale for their practice. So for Neighbor Island in the July 1st, we're implementing a 15% differentiation on top of the Oahu Medicare fee schedule. I mean, primary care fee
Speak to
schedule.
that because there's a lot of confusion in the community around the fee schedule. When clinicians in the community, was it 2017 that we signed? So we transitioned in 2017 to the payment transformation model. At the time, if I'm correct, we were all using the 2013 fee schedule. What fee schedule will be in effect, not for the rural communities, Oahu doctors, as of July 1st?
2026.
And where is that published?
The
right now?
2026, and I think we have a website where we know what the fee schedule is.
But it's not out yet.
I think it is out.
At least in the community, there's a belief that it's not publicly available. So if they wanted
we
to see
we can take
the
that.
HMSA 2026 fee schedule, where should they look?
It's a MAC rate. It is a 2026 CMS fees, Medicare fee schedule with a differentiation for the commercial. So today we are roughly 100x% of the Medicare fee schedule for commercial. 2026, CMS raised the Medicare fee schedule for primary care in the bundle-ish ways, an average about 8 to 9%. So this is not, CMS has not touched the fee schedule in the last decade, so with a pretty substantial increase in the most recent 4 or 5 years, especially post-COVID. So I think that's just catch up education about what the current fee schedule level is.
And you're saying there's also a differential fee schedule for the Neighbor Island?
For the Neighbor Island.
And that is published. Where can one find it?
I would take offline to
Okay.
figure out when
Okay.
it is, and let us know what be best way to.
A lot
to
of the
reach out.
clinicians are curious. And
Yeah, we're also doing some outreach to the Neighbor Islands in the coming days. So that's one piece. The others, we are retooling simplified quality incentive, which is a differentiation today for HMSA's payment mechanism. We will contain that, retain that, compared to our national or local competitions. For PEDS quality, we want to triple from the previous levels. So it's really a significant increase for the pediatricians' quality payments. You kind of shifted the mechanism by rewarding the quality outcome. And transition type of a hardship program.
I want to also ask, when it comes to the payment transformation model, a lot of was shifting away from acute care, looking at the patient as a whole and having a longer view with regard to their health. In addition to workflow and differences in which you manage your business, in came a rush of managing activity with a patient to non-patient facing time. That's if you're on Epic, those are your MyChart messages, the telehealth, all of these things that are sort of happening because you basically had this quarterly payment that was supposed to, one can argue whether it justifiably covered it, but it was supposed to cover it. As that disappears, is there an expectation on HMSA's part that all of that revenue now has to become patient-facing time or live visits? What happens to telehealth? What happens to all those MyCharts and phone calls that have been, that the general public has now become accustomed to receiving without having to come into the office?
I believe the virtual care has really evolved and is stabilized to as a part of a channel to access to care. Those continuous stays. HMSA's online care it's pretty mature and stable and go through its own algorithm as long as it's a clinician rendered services. So that all going to stay. And I mentioned the quality program, retool it, make it achievable. Our quality program for adults used to have like 10 metrics. So a lot of variation, individual clinician can maximize the receivership for those, now down to 3. Okay. And all these is a part of a feedback we hear. But I want to mention one thing for the whole concept. Once in a while, as we look at the results, it's inconveniently and daunting that with the mounting pressure for healthcare, utilization, and so on and so forth. The last 3 years, our population in composite overall medical loss ratio has reached 96% and stubbornly stay there, won't come down. So while the intent is great, investment is substantiated. Something's missing to allow our primary care physicians to be the quarterback to managing the overall piece of it. And it's not fair to saying, try harder.
Well, along those lines, what was the primary care physicians were partnered through a certain organized medicine, the physician organizations. And the physician organizations now exist having administrative funds specifically to help the primary care physicians in the community navigate and be successful with the payment transformation model. What happens to that income for the physician organizations? What happens to that role that the physician organizations have been playing for the last decade?
We are retooling that as the overall concept goes back to the fragmentation between the primary care, specialty care, ancillary, and inpatient stay, try to cut across, go back to the original vision. We're just going to try to introduce a different concept with some enablement capability is a market proven.
Okay.
And PO plays a significant role in that integration. And I use the word integration. And the concept called integrated delivery network and has not been widely spread in this market, but that's kind of concept. How do we extract the POs? Today, if you talk to individual POs, each group has some best practice. It's kind of contained in that POs. It doesn't get to spread. They also don't have the tech stack to get them connected. Why everybody's on the EMR? And some, even within the systems, the specialists not quite talk to the other side. So its own variation about the level maturity for the integration. Our thoughts really channel and spawn off this new payment transformation change to relaunch and allow the care journey throughout the different PO organizations, but that's including and beyond the primary care, specialty care, ancillary, and some facilities with aligned incentive. So this is not ever meant to be a takeaway. This is intended to get to a tighter connection between the front end and the back end. The plan have to survive as well. No plan can survive 96% of a medical loss ratio.
I'm hearing so many things as you describe this. At the end, for internal reasons, and I do not mean this in a negative way, a decision was made that the direction that HMSA was going was not sustainable. So that influenced your decision to bring the majority of the community back to a fee-for-service model. What's being presented to the community is under One Health Hawaii is that this group will become the group in which you can almost model out, I think, what you tried to do over the last decade, but with a more controlled environment, meaning it's a set group of patients. You'll be able to measure, because you're dealing with one health system, your quality measures. I'm assuming you'll have more access to the EMR and therefore can be able to see and to manage the things that it sounds like you struggled in the past. And one need not say whether that's good or bad, but in order for that to be successful, and you said that earlier, you need to be able to control your attributed lives, which means locking them down. In order to gain the most in terms of whether you see it in profit or the highest scores in quality, one would almost choose the healthier patients. And it keeps coming back to that question that the community is asking. If that's going to be, if part of the goal is to prove a model under One Health Hawaii, what is going to keep you from not using those variables to your benefit?
Well, let me just say, first of all, it's not just One Health Hawaii. Yes, I think One Health Hawaii in the future, which it doesn't exist yet, right? As
Yes.
we mentioned before, is regulatory, hopefully will be a great model for this. In the meantime, we're creating a model ourselves, right? It's the independent providers. And Jenny mentioned, I don't want it to get lost. She mentioned enablement services. The whole idea behind bringing enablement capabilities into the market is to take independent practices and allow them to aggregate, communicate, use a tech stack that can work to create integration with themselves and prove out the model with that as well. And I think that is just an amazing opportunity to take our independent providers and make them as high functioning and high performing as any other system could ever be.
Yeah, I think the here now is probably my priority and concern. And the vision is to be shaped by the finalization and approval of the One Health. Then the journey just began. But today, HMSA's, I'm using Medicare as an example, paying a premium that deal with a fragmented sort of a system itself. And our benefit structure is not that competitive. And the only reason the seniors choosing us brand, age in, this terminology from commercial members enrolling into the Medicare, right? And this state also aging. Today's broader community, just the organically Hawaii provider output itself, does not naturally lend itself to a 4-star market.
Right.
That is absolutely challenging to survive in the Medicare reimbursement model itself.
Right.
And that is a threat. It's not even a profit.
A threat to HMSA.
A threat to HMSA, if not for the state. Because I really view this not-for-profit single blue plan with a single state, we're bound to be together. We need each other to make it work.
Okay.
If we still want a local controlled, mission driven, and with our broader mission, we have the responsibility to figure it out, how to elevate the broader clinician output to make ends meet in this highly regulated, a new trend wave coming at us, a tightened health economic environment.
Okay, thank you. I'm going to shift over to some of the questions. So these questions are going to get spicier. One question that, interestingly enough, comes from more the employer perspective. And the question is as you're transitioning forward, will there be more transparency with costs and ideally in real time? Is that part of your strategy moving forward?
I mean, transparency and cost is always our aspiration. It's not as easy as you might think.
Mhm.
The tech stack you need, the ability for and I could go off on how AI is going to make this more possible, but then we'd have to stay here another hour.
No, please.
But there isn't yet the technological capability to have full transparency on costs, because costs come in the form of what a provider charges, what a contract says, what a pharmacy benefit says. We don't have the same pharmacy benefit. The pharmacy benefit may not be the same plan as us.
So from a technological standpoint, where you are now, there's not likely to be a big change in the next 2 to 3 years.
Incremental, I think.
Yeah, I that's why the part of a claim-based, encounter-based activity will make a meaningful step forward.
Okay.
And not just the employer, I think the clinician want that. One of the feedback we hear loud and clear in our roadshow is, help me, give me the clinician performance data.
This one comes from, I didn't attend, so obviously this is someone who attended the Hawaii Pacific Health Board Retreat that occurred just this last weekend. And I think when the topic of One Health Hawaii came up, there was a statement, and I think you're the one that actually made it, that primary care physicians are seeing 30% less patients in the payment transformation. The question is what was the implication that you were making? And is this really problematic when the goal is around not acuity care, but long-term care and long-term health goals with the patient?
Yeah, so our data does show that if you think about pre-COVID to now, the number of primary care visits is down about 30%. There's nothing fundamentally wrong with that, but a couple of things that go along with that is urgent care visits are up over 30% from that same time period, and ER visits are up over 30%, and cost of care is up 50% since that
Well,
time.
one
So-
could argue when you created a platform in which clinicians were reimbursed for seeing well, not urgent, that created a shift of urgent visits out into the community.
Right, but
Mhm.
again, so the result of that, not passing any judgment on anybody,
Mhm.
it's the fact of the matter is that the cost of care has
It's going up.
significantly been driven up, and the care is being delivered in more highly acute, more expensive settings. And that is just something that has to be fixed. And then you heard the other piece that Jenny referred to is that the payers, whether it's large employer groups or the government, just said, we're not paying for that anymore, right? We need the encounter data in order to make payments.
Understood. You know, we have about 5 minutes left, and I really wanted to thank you for, just taking the time. I know you don't have answers for everything, but the point is for the community to hear what you're thinking, the logic, and they can decide for themselves. Earlier, I told you I thought we should end on a positive note in such a changing time. And the question I'm going to put before you, and like I said, we only have 5 minutes between the two of you, is when it comes to healthcare in Hawaii, what gives you optimism about a future? And what do you think is most important as and I emphasize on the pronoun we, want to preserve, what healthcare should actually look like for our entire community?
I'm this kind of schools want owning my own destination, and there's a window for that, and I think the sense of optimism. I've limited 2 years and have exposure to the local communities, providers, and health systems, and just everyday peoples. It genuinely cares about our community. We are just all part of it, and we believe that our way of life should be preserved, especially the rest of the world is kind of in an interesting space.
Crazy.
And I'm deeply grateful. You should talk to my husband. He's deeply grateful. But sitting still probably is not gonna work well for all of us.
Okay.
And that's the personal commitment. But change need to be bounced around each other's. Check once in a while, is everybody still into it? The willingness to step forward to it. I think we are in a very daunting, interesting time in the history, if not for healthcare. You wanna trust for the people that have the best knowledge how this market works. The clinician have generations practice to serve this community, have a way to say, long or short of it, locally control the solution that have the best interest of people in mind and heart.
And hopefully ensure that it includes physician leadership in these discussions. Mark?
The reason why I'm optimistic is because I have the good fortune of being on the Blue Cross Blue Shield board. And I watch how, when I first started, there were 37 other plans and how they were interacting with their own state. Because of all the problems, they've consolidated down to 31 now, which we don't want to have happen to us. But I say that because I can see how different states and different geographies approach it. And we are unique in Hawaii. We are the only place where almost everybody who's in the healthcare space, whether it's a payer, a provider, a health system, and independent practice, we actually have the same purpose. There's nowhere else like that. That gives me optimism, because I think the way that we solve these problems is together. And so if we can understand that we're all going toward the same North Star, and respect each other's perspectives and work on it, I'm optimistic we'll find a way to help Hawaii.
Okay, thank you both. So as we close tonight, I want to thank Dr. Mark Mugiishi and Jenny Smith for being willing to sit down with the Hawaii physician community to have an open and thoughtful discussion and give us basically their message that they want us to hear. The challenges that we're facing, that they're not simple and no one group is going to solve them. It's going to take, as Mark said, a great deal of collaboration, physicians, hospitals, payers, policymakers, employers, and the community itself if we're going to build a healthcare system that truly works, as you said, locally for Hawaii. Tonight, we were just about creating a space that we could have a little bit of an open dialogue. We tried not to get too spicy, but we do appreciate your transparency, respecting and at least attempting to answer the physician concerns to give them and the community a better understanding of what's on the healthcare horizon for healthcare. Again, the Hawaii Medical Association appreciates your presence. And with that, I'll say adieu. Thank you very much, everyone.
Thank you.